So I'd like to introduce to you our first presenter, who actually is my endocrinologist. And I was really honored when she said yes, that she would speak, and actually on the subject that I wanted to cover. But I also want to let everybody know that, very quickly, that Dr. Johnson, I really wanted to meet an acromegaly patient and I couldn't. Patient confidentiality in Canada. Drives me nuts. Anyway, so I said to Dr. Johnson, I said, that's it, I'm starting a support group. It's got to happen. I did not know about the Halifax, but I shortly found out that there was a Halifax support group, but they're like way that way. So Dr. Johnson had heard my journey and understood my desire and need. So Dr. Ure, who moved from Halifax to Vancouver to become our endocrinologist here that runs the endocrinology department for VGH and St. Paul's, they got to talking. And their little talk was able to bring me the help that I needed to get started with the support group. So I just want to say thank you very much to Dr. Johnson for believing in me, and Dr. Ure for coming on board and making this happen. So on that note, I'd like to introduce Dr. Johnson. Dr. Johnson completed her medical school and intern medicine training at the University of Manitoba. She studied general endocrinology at the University of British Columbia. Then she completed an additional pituitary fellowship at the University of Virginia, working in a pituitary of excellence. She has been a member of the UBC Division of Endocrinology since 2002 and is the lead for pituitary teaching in the medical school, which I was honored to present with Dr. Johnson last year at UBC. That was awesome. Dr. Johnson also teaches residents and fellows in her clinic. And Dr. Johnson also participates in clinical research related to pituitary disease, including acromegaly. Please welcome Dr. Johnson.
Thank you very much. It's a real honor to speak at this conference. Thanks to Deanna and Peter for inviting me. And again, thanks to the pharmaceutical industry for supporting this event. And I think she's thanking us, but we really want to thank her for having the motivation and the enthusiasm to get this group started and to see what she's done in really only a short period of time. It's hard to imagine where she'll be in another 2 years or whatever. And I'm going to be talking about how the different treatments for acromegaly and how the endocrinologist decides on the treatment. And I must say that I've given lots of talks to residents and family doctors, even endocrinologists in the community, but I'm not sure I've ever given a talk to a group that's probably as knowledgeable as this group, because you live with, some of you live with the disease or are close to people that have the disease and understand it more than anyone else. So in this next hour, I'll just give a little background. We'll talk about what our actual goals of treatment are. And then we're going to spend our time talking about what the treatment options are: surgery, medical therapy, radiation, but mostly concentrate on the medical therapy, because as an endocrinologist, that's what I do. And I'm going to put a few little case examples throughout the talk so you can sort of see how I'm making my decisions. So first of all, you guys know this is a rare disorder. In older studies, the prevalence is about 60 cases per million people. But in more recent reports, we think it's probably a lot more common and it's just being undiagnosed. So some of the recent reports suggest that it's hundreds of cases per million people, or even thousands of cases per million people. But just to give you an example from those older studies or traditional studies, if the population of British Columbia is 4.7 million, then that would mean there's about 290 patients with acromegaly. And for Canada, with a population of 36 million, then there's about over 2,000 patients with acromegaly. But we suspect that may be 10 times higher than what we're even saying. Because that's a common question that sometimes people have. They've never met somebody with acromegaly, and now we're so fortunate that I can give them a card, and even if they don't want to officially join the support group, they can get information from the website. The average age of diagnosis is between 40 and 45, so really this is affecting people right in the kind of prime of their life. And it's almost always caused by a benign growth hormone producing tumor in the pituitary. There are some other causes that are more rare, but our discussion is really going to focus on growth hormone tumors from the pituitary. So of course our goals are to reduce all the signs and symptoms, to reverse all the things, changes that have happened to the body, and to improve quality of life for our patients. We also want to control the tumor volume itself. We don't want it to be growing and putting pressure on the eye nerves. And with whatever treatment we choose, one of our goals is to avoid damaging the pituitary and to avoid side effects from the medication. And of course, we want to normalize our labs because we know that's when all of these other things improve and people's life expectancy returns to the normal population if we make your labs normal. So we want to get a normal IGF-1, and that should be compared to an age and sex-matched normal range. And in BC, they always report it that way, so you don't have to worry about it. When you see your IGF-1, whatever they put in brackets as normal is based on the fact that you're a man or a woman and your age. Perhaps in other provinces, you might need to make sure that they're reporting it with the right normal range. And that we want to also achieve normal growth hormone levels. So ideally, during one of those glucose suppression tests, and Dr. Dan Holmes from biochemistry will be talking about testing later, so I'm not going to focus on that too much, but when you drink that sugary drink, at some point during the 2 hours, your growth hormone should go down to less than 2. Oops. How did I do that? I just touched it. I think if I touch this. Peter, I'm sorry.
Is that one of your trips, Peter?
It's not even on the screen right now. I'll keep talking while someone, I know I'm supposed to use these.
Sorry.
And that we don't always do that glucose suppression test, but you know, it's suppressing down to 1 correlates with a growth hormone randomly of being less than 2.5 or fasting being less than 2.5. I'll resist the temptation. I was kind of like trying to use the cursor.
Okay, so we'll just have to advance to the side you're at.
Yeah. Okay, perfect. So first of all, one of the options is pituitary surgery. I feel like I'm just gonna, I got that right? Yeah. And it is actually first line in most cases, and you're probably going to hear a bit about this from Dr. Acromegaly, or you've heard about it at other meetings, but that they go transsphenoidally through the nose. And I think one of the things as an endocrinologist that I want to emphasize that it's really important that you have an experienced pituitary surgeon, that there's good published data that shows your outcome from your surgery is better if somebody is doing your surgery that does a lot of pituitary surgery or has experience in the area. And one of the reasons why surgery is first line is that, trying to remember which one, there's the pointer, there's a chance that you could be cured. We try not to use the word cure anymore. We really kind of say more remission, because even people who have very successful surgery and they are cured, their IGF-1 is normal, the growth hormone is normal, there's a chance of recurrence down the line. So if we use the word remission, then people remember that this is something we need to be careful with and make sure that you're getting checked annually to make sure it's not coming back. But this is just an example of a normal MRI of the pituitary. So, you know, it's kind of cutting through your head like this, and so your eyes would be kind of in this area and your nose in front, and this black area is the sinus behind your nose. And I always say that the pituitary kind of looks like an anchor. So this is the stalk, and this is the normal pituitary. And this is like your eye nerves crossing above. So there's lots of space in between the eye nerves and the top of the pituitary. And this is an example of a person who has a microadenoma. So that's just a small tumor. That means it's less than 10 millimeters. And so this area that isn't lighting up as well is the tumor. And one of the reasons why we think, for the most part, people with small tumors should have surgery is because they have a chance of being in remission, quite a good chance, like 70 to 90% chance of being put into remission, not needing medical therapy, not needing radiation, and so they just need to be monitored. The other group of people that probably should have surgery are people who have very big tumors. So they're called macroadenomas if they're bigger than 10 centimeters. But especially if it's really big and it's pushing on the eye nerves, and if it pushes on the eye nerves from below, people can lose their peripheral vision. So those people, even if the tumor's off invading places and we know the surgeon can't get rid of it all, it's still important that they have surgery to take out as much as possible to, we call it debulk it, so that then it takes the pressure off the eye nerves. so that they can have immediate improvement in their vision, whereas they have to wait longer for medications to work. So that is a reason for them to have surgery, even though we know with these bigger tumors, their chance of going into remission with surgery alone is much lower, like maybe somewhere in the 30 to 50% range, but their chance of improving their vision right away is very high. So who wouldn't have surgery? There are circumstances where maybe the surgery is just too risky because the person has other health issues. Maybe they have cardiac problems that need to be dealt with first. There's some people that maybe have, unfortunately, shorter life expectancy. Maybe they have a cancer that they're undergoing treatment for, so it's not appropriate for them to have a pituitary surgery. Sometimes it's just there are times where it might be just the patient's preference not to have surgery, and that they could try to see how, if the medications work for them, then maybe they can avoid surgery. And one could argue if it's a really large invasive tumor that's spread off into the areas where we know the surgeons can't get it, but nowhere near the eye nerves, if not much can be taken out with surgery, maybe there's no point going to surgery because they're just going to end up on medicines anyway. But the bottom line is that in Canada, for the most part, people go to surgery first, and for good reasons, because taking a lot of it out can help the medicines work better, and then sometimes it's because you can be put into remission. So if you can't have surgery or surgery doesn't take care of it all, then the next step is medical therapy. And there are some medications that are geared at the tumor itself. So just the way surgery and radiation is obviously geared at the tumor itself, the two classes of medications that we're going to talk more about, dopamine agonists and somatostatin analogs, they're acting on the tumor itself, or receptors that are on the tumor. Whereas there's another class of medication that we're going to talk about called growth hormone receptor antagonists. They don't do anything to the tumor, but they block the growth hormone from acting on the growth hormone receptor so that you don't produce IGF-1. Again, we're going to go through that a bit more. But to start with the dopamine agonists, so there's actually 3 dopamine agonists that are available in Canada. There's cabergoline, there's quinagalide, and there's bromocriptine. And we, as endocrinologists, use these medications a lot to treat prolactin-producing tumors, and they're really successful in treating prolactin-producing tumors. But that some growth hormone tumors also have receptors for dopamine, so can respond to this class of medications. Cabergoline is superior, it's better, more effective than quinagalide and bromocriptine for acromegaly. So for the purpose of today's discussion, we'd be talking about cabergoline, and its other name is Dostinex. And some of the reasons we might want to try this is because it's taken by a pill. It's the only one of these medications that's a pill. It's less expensive than the other medications, and that it can normalize IGF-1 if you select the right group of people. So in about 25 to 35% of patients, you can get normal IGF-1 levels, but that's when you're choosing people who have fairly mild acromegaly, like their IGF-1s are they're less than twice above the normal range. As far as side effects, particularly when we first start them, some people can feel nauseated, some people can feel lightheaded or dizzy, some people have, I didn't write this, sort of a brain fog or constipation. It generally goes away as you take it, and many people have no side effects at all, but it's something to watch for and sometimes a reason why we can't continue with it. The other point that I'll bring up again at the end is that sometimes we add this medication to the other drugs later on, and even in people who maybe it didn't seem to work on its own, it can do something when you add it to the other medications. So it definitely has a role in acromegaly. So this is my first little case example number 1. So this is a patient who had successful transfemoral surgery for a very large pituitary tumor, and the surgeons were unable to get all of the tumor. There's some left in the cavernous sinus. That's that area that's off on the side where your carotid arteries run and some of the important nerves to your eyes run, and so the surgeon can't safely get in there without causing harm. So there's no way that little bit can be removed with surgery. And the person's IGF-1 is persistently elevated. We've waited to see if it might come down, but they still have a little bit of active disease. But the IGF-1 is not too bad. It's 246, and normal is 54 to 189. But still, our goal of therapy is to normalize it. And maybe they had a little bit of symptoms. We'd like to give them optimal therapy. So this is a person that I would eagerly try cabergoline with at first, because we probably at least have 25-35% chance that that's going to work for them. If it doesn't work, or if the IGF-1 is much higher, our main class of drugs are the somatostatin analogs. So I'm going to kind of abbreviate that as SSAs when you see that. That's somatostatin analogs. And the original ones, the ones that you guys will have heard about the most, are sometimes called the first generation somatostatin analogs. And there's two that we use here in Canada. One of them is called octreotide, and its other name is sandostatin. And the other one is called lanreotide autogel. Its other name is somatuline. For octreotide, there actually is a short-acting form that's given 3 times a day by a small subcutaneous insulin, you know, kind of like an injection you would do for insulin. And then there's the long-acting form that's given every 4 weeks by a needle that goes into the muscle. And in acromegaly, we really pretty much always use the long-acting form, so that's more relevant. And they have 3 different doses, at 10 milligrams, 20, and 30. And with the autogel is similar. It's given every 4 weeks. The needle's not quite as long, and I'm going to show you a little bit more about the differences down the line here. But it's a deep subcutaneous, but it's still going into generally the biggest muscle, the buttocks there. But it's deep subcutaneous. And with somatuline, they do have a study that it can last longer than 4 weeks. So if people have really good control with every 4 weeks, you could reduce the dose, but you could also, instead of reduce the dose, you could increase how much time in between you give the injection. So you give it every 6 weeks or even every 8 weeks. And that's being approved to do. I will tell you that sometimes off-label, people will do that with sandostatin, but it hasn't been officially approved because there aren't really like studies that have supported that. So that's one little difference there. Sorry, I'm kind of going backwards here. So how well do these somatostatin analogs work? Well, honestly, it really varies between what study you read, and the differences in the studies are because it's different patients in each study, but it's anywhere from 25% to 75% of people will get a normal IGF-1 with one of these first-generation somatostatin analogs. And it seems like the earlier studies that were showing more, you know, that 60% or 75% of people were getting normal IGF-1s, it might have been because they were kind of selecting patients that they already knew had responded. Maybe they'd had that subcutaneous form, you know, that I had told you, they had done well, so then they put them in the study of the long-acting, and they got really good results. But they'd already kind of selected people that were responding to that medication. And if you look at more recent literature, like studies that are just kind of looking in the real world, people who are never been exposed to any drugs, we're not sure what they'll respond to, then really it is lower amounts of people, maybe on average we'd say 40 to 50% of people will get a normal IGF-1 with the somatuline or the sandostatin. And then I think one thing that I'd like to emphasize is I really think the results are very similar between those 2 drugs, that one is not better than the other in achieving normal IGF-1 levels. And obviously we'll still come back about then how do we choose these medications. This is, you don't have to look at the details, but just an example, I wanted to, when we're talking about how well do these medications work, this is an example that's using octreotide or sandostatin, and these are individual people. Like, this is one person in a study. These are 24 people that were in this study, and they'd never had any other treatments before. And their IGF-1s are starting where this open circle is. So, you know, they're starting with high IGF-1s, like this person is 1,000, this person is 1,500. And then where they end up is after they've been on the medication for 24 weeks. So even though, I'm really struggling with this, sorry guys. It's the intuitive of the forward, backward thing. No. I feel like I have a little thing that pops up there. Maybe I'll just read it off my screen. That overall in this study, I think eventually it will come, 42% of patients had a normal IGF-1. So again, that's kind of what we said, maybe overall that 40 to 50% of people might get normal IGF-1s, which to me sometimes that sounds kind of like, well, not that great. That's 50 to 60% of people that are not getting normal IGF-1. But it doesn't, I just want to point out that it doesn't mean that the drug is not working, because, I'm really sorry. that, I need to take a minute to say the top is the laser, that 42% of people got a normal IGF-1, but look at, actually everybody had actually a pretty good response. It doesn't mean that the medication isn't working. It might be making your IGF-1 go from 1,500 to 600. You feel way better, and it doesn't mean you should stop the medication. It just means that you might need something in addition to it. So I just kind of wanted to point out that 40 to 52% might make it sound worse than it is, that many more people are getting a response. We're just not a good enough response. So how do these medications actually work? So normally there's actually something that comes from the brain in the hypothalamus called growth hormone releasing hormone, and that normally goes to your pituitary, tells you to make growth hormone. The growth hormone goes to your liver and other tissues and tells you to make IGF-1. If you ever see the word somatomedin C, that's the same thing as IGF-1. There's also something that some people call it growth hormone inhibitory hormone, but it's also called somatostatin that comes from the hypothalamus, and it inhibits or it reduces your growth hormone production. So this happens naturally. We make somatostatin. It keeps our growth hormone levels low when we don't need it. And so these drugs that they're making are just made to be like somatostatin. So they're acting on the pituitary itself. They're acting on receptors on the tumor. And the reason I bring that up is to show you, well, here, the two drugs, that there are actually 5 different receptors for somatostatin, and that these first generation drugs, they work on 3 of the receptors, mostly on 2, also on 5, and a tiny bit on 3. But the pituitary tumors have a lot of receptor too, so that's good. That's why these medications can work. But that's one of the other things to point out, that these medications not only can lower IGF-1, that they work on the tumor itself. So this is an example from the other drug, from lanreotide or somatuline. And what this is trying to show us, this is a study of people that were followed over 48 weeks, and they were given medical therapy with this drug, and that by the end of the study, 63% of patients, their tumor had shrunk by at least 20%. So these medications are shrinking the tumor in the majority of cases, in addition to lowering the IGF-1. And that you can see in some individuals, that's quite dramatic. This person didn't have surgery. Here's their big tumor at baseline, and here's 12 weeks later, it almost looks they've had a resection, but that's just the medication reducing the size of the tumor. So not everybody has that great of a response, but some people can, and that's why you might have a circumstance that you were planning to do surgery, but somebody responds so well, and maybe this happens to their tumor, maybe their IGF-1 normalizes, and in the end you decide you're not going to do surgery because you've had such a good result from the medical therapy. It's also, this isn't kind of what I'm talking about today, but this is also the reason why we're interested to know whether or not taking a medication like lanreotide or octreotide for 3 months before surgery, in some cases, might improve your outcome from surgery. If you have a little small tumor, then not. You should just get your surgery as soon as possible. But the bigger the tumor is, the more you might say, well, if we shrunk it down a little bit, then maybe the results from surgery would be better. And the reality is, as much as our great surgical colleagues are trying to see people as soon as they can, but they have limits on their office space and the OR time. So the reality is, it's very rare that people get surgery right away. So I often will give them medical therapy for 3 months in advance, and at least we're giving it a shot to see if it might improve their outcomes. And we should have more proper information on that, because it's something that we're studying in more systematically. So what are the side effects with these drugs? Well, about a third of patients do get stomach stuff. They get nauseated, abdominal discomfort, loose stools, and this tends to happen in the first few weeks of therapy. But what we find is it spontaneously goes away over time, and such that the next injection it's less, and the next injections it's less. And some people do notice for a day or two that they have some GI symptoms, but it usually doesn't limit them from taking the medication. But there are some people that just disagrees with them, and we have to stop it because it's not working well for them. It also can reduce, both of the drugs can reduce your insulin secretion a little bit, and then when you reduce your insulin, your blood sugar can go up a bit. So we have to monitor blood sugars, but luckily that hasn't really panned out to be a big problem. We're not seeing people develop diabetes from these medications. It just might be that their fasting blood sugar goes from being 5 to 6, so it's not, fortunately, a big problem, but something to watch for. It also reduces how the gallbladder contracts, and so some people, actually about 25% of people will get gallstones or thickening, at least, of the gallbladder fluid, and you can think, oh my goodness, nobody checks my gallbladder. Well, you're not really supposed to, because in the studies, it's shown that these are not symptomatic stones, so there's nothing that we do about it, and it's not changing our management if we see it or not. But if anybody gets symptoms of gallbladder disease, then they should be investigated just like anybody else. And that, fortunately, it hasn't turned out to be maybe as much of a problem as people might have thought it could be. Again, so how do we, I've just told you that I believe that they're very similar in how well they work, and I believe that their side effects are very similar, and this is what the literature supports. So how do we decide between the two? For some places, it might be a matter of coverage or cost. In British Columbia, we're fortunate at this point that they're both covered through the BC Cancer Agency. So even though these tumors are not cancer, there's an umbrella of money that covers these medications that treat the tumor, and they're both equally covered. There was a time a few years ago, because Somatuline is newer to North America. It's not newer, it's been used in Europe for a long time, but it's newer to North America. So at first it was harder for us as endocrinologists to prescribe Somatuline. There were extra steps to get it covered, but now it's equally as easy to get covered. So it really might just come, and they both have excellent support programs so that you can, it helps the physicians and it helps the patients get started on the medication, and over time a trained nurse can give the injection in your home, and both programs are established. So it really might just come down to the slight differences in the actual injection. The needles are a bit different. Also with Somatuline, it has a preloaded syringe, so in theory, it's been approved that a patient can give themselves their own injection, or their friend or spouse could give them the injection, whereas the Sandostatin requires some mixing, and it hasn't, there might be the odd person who does it, but that it hasn't been approved, at least, to do self-injections. It should be a health professional that's giving the injections. And I'll just show you a little comparison here with them now as well. So this is what comes in the kit for Sandostatin LAR. So there's the powdered vial, and then there's the syringe that contains the fluid that you're going to mix in with the powder, and then there's this adapter that just helps you get the fluid into the syringe, and then the needle, the safety needle that you inject it with. Sorry that this is on the side, but it's just the way it worked out. But it's just to show you, this is what it looks like when it's all together. It's 2 milliliters of fluid. The needle is 1.5 inches long. The gauge is 20 inches. And that, as we talked about, it goes into the muscle. And then, whereas just a picture of the Somatuline, the volume's smaller. It's half of a cc, and the needle is shorter. And that's why it's going deep subcutaneous as opposed to intramuscular. And the needle's a bit bigger, though, actually. It's a little bit wider. So there are some differences, and I'm sure there's people in the room that could speak more about the differences, but that's what it is kind of visually. Sure.
The molecule size, is the gauge of the needle that big because the molecule size is that big, or can it be changed to a smaller?
No, it can't be changed. The liquid, or what you're injecting, is fairly like viscous and kind of thick, so it wouldn't go in with a smaller needle. So you would have trouble injecting it, like you really couldn't do that. So I'm going to give you 2 other kind of examples here. So this is a 67-year-old patient who has underlying heart disease, and in fact, her cardiologist is thinking that she might need to have bypass surgery. She really strongly prefers not to have surgery, and she's even nervous about medical therapy. She's got a fairly large tumor, but fortunately it's nowhere near her eye nerves. It's not affecting her vision. Her IGF-1 is 700, normal's 38 to 164. She lives outside of Vancouver in a smaller area. What would I prescribe for her? This is not a 100% yes, but this might be a patient where I would choose octreotide or sandostatin. We're not going to give a dopamine agonist. The IGF-1 is too high. The sandostatin's been around a bit longer, and she's nervous. She's asked me, what medication have you prescribed the most? What's being used the most in Canada? Their support program is really quite well established, and they can outreach to lots of places. So that might be, but I could have just as easily picked lanreotide. And then example number 3, a 42-year-old man who's got residual tumor despite a good debulking surgery, and his IGF-1 is 500. He travels a lot. His schedule is very variable. So again, not a good one for dopamine agonist. I really have to apologize. I just can't get this right. But I think, is the bottom going to go forward?
Yeah, the bottom goes forward.
And the top is okay.
Yeah,
This is really, the top is the laser though. It's top and the bottom, not the middle.
Garnett, where's the old one?
Yeah, I know, he told me, it's not his fault. But this is the laser. So this person, I would think maybe lanreotide might be a nice choice because they could, in theory, learn how to give the injection themselves, or a friend or a spouse could give it to them because of the preloaded syringe, etc. So now there actually is a newer class of somatostatin analogs, the second generation, and the name of it is called pasireotide, LAR, or Signifor. And it's also given by an injection every 4 weeks. It has 3 doses available, 20, 40, and 60. And it's actually made by the same company who makes sandostatin LAR. So the actual way the injection is given is exactly the same as sandostatin LAR, is the exact same support program. So if you switched from sandostatin to Signifor, you wouldn't notice any difference, really, as far as what the injection is like. And that this acts on more somatostatin receptors. So remember, the other one was mostly on 2, a little bit on 5. Well, this one still has good effects on 2, but more effects on 5 as well as other receptors. And these are receptors. 5 is also found on these pituitary tumors. So people wondered, well, maybe because it's acting on more receptors, it's going to be better than the other ones in controlling IGF-1. And in fact, that seems to be the case. And this is an example of a study where you can see they didn't really, even in the people who got LAR, only 19% of them got normal IGF-1s. But again, remember, a lot of them probably their IGF-1s lowered. They just didn't completely normalize. But that definitely more got normal IGF-1s with Signifor. So the logical question is, why aren't we using that? Why hasn't it taken over? Well, we'll come back to the cost issue. But the other thing is that its effect on reducing insulin is stronger. And so we said that blood sugars we have to watch on the first 2 drugs. Well, we really have to watch it on the Signifor, that over half of patients were getting increased blood sugars, and not just trivial, like to the point where they had to go on medications or even take insulin therapy. So that's why you haven't seen it take over as a medication used a lot. But here's a little case example. So patient who had some improvement with IGF-1 with the first generation somatostatin analogs. So we think they have receptors for somatostatin. That drug seems to work, but we can't normalize their IGF-1. And this is kind of an aggressive or more invasive tumor. The patient's already had surgery, and because it was sort of growing, they've been sent for radiation, but yet it's still growing, and we're really stuck. Nobody wants to reoperate again. And at this point, we're really worried that 1, we're not controlling IGF-1, but 2, the tumor is growing. So this could be a person where I would try pasireotide or Signifor, because it might lower IGF-1 better. It might shrink the tumor better because it's acting on those receptors, and it's kind of there's not a lot of other choices to have at this point. Then to switch gears to talk about the growth hormone receptor antagonist, so this is pegvisomant, or its other name is Summervert, and it's given by a daily subcutaneous injection. So that's a smaller needle, like you would do for insulin. So it usually goes into your abdomen, and it comes in all different, like it starts at 10 milligrams and goes up by 5s up to 30 milligrams. And this one, just so you guys know a little bit what's happening. So normally the growth hormone that comes out of your pituitary has two binding sites. So, and it binds to half of the growth hormone receptor, and then the other site binds to the other growth hormone receptor. And then when those two receptors come together, it has a fancy name, it's called dimerization, and that's what leads to higher IGF-1 that causes the mischief in your body if it's too much IGF-1. But so pegvisomant is kind of like growth hormone, but it's been modified so it binds to one site, but it can't bind to the other site. So you can never get that dimerization. So it doesn't lead, so your IGF-1 is not produced, so it lowers IGF-1 because it's preventing, not only, it's blocking the receptors, so all the growth hormone that's coming from your tumor can't act on the receptors because they've been filled up by the pegvisomant. So the important point is that it's really good in normalizing IGF-1, but that you just have to remember it's not doing anything to growth hormone itself or to the tumor itself. And so, in fact, you shouldn't measure growth hormone when you're on it because it's usually a bit higher, if anything, because you're not doing anything to it. And this is just an example that shows you, again, it's that same idea. They like to do these in studies where they have a point where your IGF-1 starts, and this is one person after they take the drug, and this is where it ends. And you can see in this study, like, really, they're normalizing IGF-1 in almost all patients that they're giving Somavert. And these are the early clinical trials where people were given this medication in study situations. And that, in the longer-term clinical trial, 95% of people got a normal IGF-1 with this medication. Now, when we look at that in real life, there's a study that's called Acromegaly that's collecting data on people who are taking pegvisomant, and they're, at this point, not necessarily part of clinical trials, they're just on it, but they're monitoring them. And it's still, 63%, that's still good, and it's probably better than the somatostatin analogs, but it's a bit disturbing. Why 63% when initially we had like 95%? Well, it might be partly just because this is the real world and maybe patients don't always take their medication, or maybe they're not getting the injection in correctly, but it's probably just as much the doctor's fault, not the patient's fault, in that in these ACRO study, the average dose of pegvisomant that was given was 17 milligrams a day, but the maximum dose is 30 milligrams, and in some of those clinical trials, they were even going above 30 milligrams. So maybe we would get that 95% normalization in IGF-1 if the doctors remembered to up the dose if the IGF-1s weren't good. So I'm just saying we need to remember, if the IGF-1's not normal and they're on 17 milligrams, well then they should be on 25 milligrams, and maybe it will be. So hopefully we could get even more IGF-1 normalization with titrating, they're changing the dose as necessary. What are the cautions? So as I've said, you're doing nothing to the tumor itself, and so you do need to be more careful about monitoring MRIs. But fortunately, in the studies that are out there, we haven't seen tumors grow just because they're on this medication. But we still think it's important that people get an MRI every year, at least for the first little while. Whereas when you're on your sandostatin or your somatostatin, if your IGF-1 is really well controlled, you don't really have to have an MRI every year, because if the tumor were growing, it would be reflected in the blood test. But here, the blood test is doing something completely different than what the size could be. So you just have to remember to do MRIs. There's also been some cases of the Somavert affecting the liver. So we are supposed to watch the liver tests, and fortunately we haven't seen that to be a huge problem, but something that needs to be watched. The other thing that really needs to be watched with caution is the blood sugars. The blood sugars actually can become lower with pegvisomant, and so people might start to get hypoglycemia, low blood sugars. But that's because they're on diabetes medications that they no longer need, or they're on insulin doses that should be reduced. So it's a caution, but it's actually a good thing that pegvisomant, in contrast to the other drugs, is lowering blood sugars. So for people with diabetes, that can be quite an attractive thing. The other ones were, if anything, making it worse, and this is making it better. So the main side effect is pain at the injection site and sometimes some reaction there, like just some redness, but most people tolerate that pretty well. They also have a support program that will help you figure out if your extended benefits pay for the medication, and if you are starting on it, then they will teach you how to give the injections, and they will even send the medication to your home, like direct delivery. So all of these companies that produce these drugs have really excellent support programs that are here to help you and I. So case example number 25 is a 26-year-old man who's got some residual tumor that just couldn't be taken out with surgery. Fortunately, it's not near his eye nerves. And prior to surgery, when he was waiting for his surgery, he had been on one of the somatostatin analogs for 3 months, and his IGF-1 didn't budge. It just stayed exactly where it was. And now here he is 6 months post-op, this young guy, and his IGF-1 is 950, which is, more than 3 times the normal range. So he would be a really ideal candidate to go to pegvisomant or Somavert, because I'm not really worried about the size of the tumor. It's not close to his eye nerves. Of course, I'm going to monitor that with an MRI, but his IGF-1 is high, and he's a guy that just didn't respond to the somatostatin analogs. We do sometimes do combination therapy. I already mentioned that we often will add cabergoline to the somatostatin analogs. We can also add it to pegvisomant, and that sometimes it won't have a huge effect, but it can bring that down just another 20-30%. For some people, it means bringing it into the normal range. And that we do have quite a bit of experience combining somatostatin analogs, so that's sandostatin or somatuline with pegvisomant, but that is all off-label. If you read the product monograph, it's not being approved. But there is published data using combination therapy, and sometimes it can be the best choice. I'll just give you verbally an example. Someone's got a tumor that you're kind of worried about the size of it, and you do think they responded a bit to the somatostatin analog, that things improved, they just didn't normalize. You might add Somavert so that you can normalize the IGF-1, but still have the direct effect on the tumor. So it is something that we do, even though that is, to make it clear to the audience, off-label and not being approved. Is there anything we can do that we know that will help us predict which medication to use? Well, there is some really interesting stuff that I hope that we'll have more and more information on as years go by here. But as you guys know, when you have your surgery, they routinely look at the tumor under the microscope, and they'll confirm that it was a benign pituitary tumor. They'll confirm that it stained for growth hormone, it was making growth hormone. And they can also look to see if there's 2 different types of growth hormone tumors, some that are densely granulated and some that are sparsely granulated. And what we know is that these sparsely granulated ones don't respond well to the somatostatin analog, whereas the densely granulated ones really do. And so if you knew that the tumor was sparsely granulated from pathology, you might go to Somavert or pegvisomant much earlier than you would if you didn't know that. Or even if you're going to go through the steps of the other drugs, you might spend a lot less time on them and get to Somavert more quickly. And in fact, it is young patients with big, invasive, kind of aggressive tumors that tend to be these sparsely granulated. And no doubt that 25-year-old that I gave you the little case where I said he didn't respond to the somatostatin analog, I'm certain if you looked at his pathology, they would say it was sparsely granulated, and that would just be further support that pegvisomant is a good choice. Now, these were not types of pathology reports that we were getting, at least here in BC. So all of you, or any of you that have had surgery, won't know if you're densely granulated or sparsely granulated. You can guess if you kind of had a response to somatostatin analog, you're probably densely granulated, and if you didn't, you might be sparsely granulated. That it's something that for people in the future, we hope we'll have that information to help us decide on their medication. And then, so what other factors influence which drug I pick? Well, I already sort of told you that the presence or absence of diabetes might affect my choice because of the things we just talked about. But then the cost. So cabergoline is relatively inexpensive compared to the other drugs. These are very rough estimates, and I'm sure there's people in the room that can correct the numbers that I put up there. It was a little bit me searching on Google because my pharmacist never got back to me, but cabergoline is generally $10 a pill, and you usually take 4 pills a week when you're taking it for acromegaly, so that would be about $160 a month. Sandostatin, this is for the highest dose, and somatuline for the highest dose. They're similar cost, sort of $1,800 to $2,000. Lower doses are less. Signifor is much more expensive, and Sumavert, depending on the dose, I usually say the starting dose is $100 a day. That's how I kind of remember it. 10 milligrams a day is $100 a day. So you can see why Pharmacare and people like that sometimes do want us to try the other medications first, but at the same time, at the end of the day, we need to get people healthy and feel good, improve their quality of life so they can return to the workforce. So whatever it takes to treat the tumor is what is best for everyone, right? But that's just to give you a bit of a ballpark. And then lastly, for the decision, patient preference plays a role. There's some people that maybe they really, really want to try doing primary medical therapy and not rush into surgery for certain circumstances. Maybe there are people that their friend took Somatuline and had a good experience, and so they want to go with that one first ahead of Sandostatin, or the opposite. We're open to what the patients think might be best for them too, and especially that we're proud that our patients have become so knowledgeable over the years and that you can advocate for yourself. But I will say that there are some caveats with the Pegvisomon or Sumavert. It's not like you can just say, I want that one. That one is not covered through the BC Cancer Agency, so it has to go through Pharmacare. So there are steps to follow before you can get it. And then finally, just a brief comment on radiotherapy, that it's really reserved kind of as a last resort, but there are circumstances where it's a good choice. So if you can't achieve biochemical control despite all the things we've already talked about, or if the residual tumor is growing despite all the things we've talked about, then it is a good idea to have radiation, and that people actually respond really well to radiation in that tumors usually stop growing. Hormone levels do come down over time, but it can take 10 to 15 years to see the full effects. And that the problem is that more than half of the patients will develop a pituitary deficiency. So you went in with high growth hormone, but you might come out 10 years later needing thyroid replacement or cortisone replacement, testosterone replacement. Ironically, sometimes growth hormone replacement. We actually do that sometimes, give people back growth hormone who've had acromegaly. Yeah. So this is a very busy slide, but it's just my final slide to summarize what I think I've tried to say. So most patients are going to go for transfemoral surgery. Hopefully they're cured or in remission, and then we just follow them. But some of them, it's going to be impossible to cure even with the best surgeons, so they're going to need medications. We also said there's some people that we might consider going straight to medical therapy just because they're not good surgical candidates, or we just know that there's very little tumor that can be removed from surgery. And then as far as what medication, if it's very mild disease, I would be completely pro trying a dopamine agonist first. But if that doesn't work, we would go to a somatostatin analog, or if the IGF-1 is just higher to begin with, we would go with a somatostatin analog. We would consider going with Pegvisomon first. It has been approved to now be first-line therapy in patients with sparsely granulated tumors or patients that have already been exposed to somatostatin analogs maybe before surgery and we know they didn't work. And if they've had some response, like things improved, they just didn't normalize, then we might add on another drug. If there was no response, no point continuing that one that didn't work, we would switch to something else. And if all of these efforts are ineffective or the medications are just not tolerated, sometimes there should be a box in here that says reconsider surgery, that we do that. But if need be, they can have ideally stereotactic radiation therapy, which just means it's more focused radiation, so less chance of side effects. And most patients for pituitary tumors can have a form of stereotactic radiation therapy. And I think that should conclude. Yes, thank you.